Hi, my name is Steve Clark. I'm a stage 4 bowel cancer patient. I set up a program called Strive for 5 to beat bowel cancer, and I volunteer with the charity Bowel Cancer UK in various roles, such as campaigning, and I'm a moderator with their online forum, so I do a lot of patient support on there. I first did this impact presentation with the Association of Coloproctology about 2 years ago now, just coming up on that. And the idea of that meeting was looking at ways of improving care of people with advanced cancer. And that was a joint meeting with oncologists, surgeons, nurses, and the charities. The feedback from that has been very, very strong, and there's a lot of initiatives that are following it. And now refilming this as an update to see what's going on, but still what needs to be improved. So I'll start by just saying a little bit about me and my background. And I should say that the presentation is targeted more at healthcare professionals, but hopefully it's going to be something that's helpful to everybody that's going through bowel cancer. So when I was diagnosed in 2013, I was diagnosed at stage 4. I had a very large primary. It was already metastasized into my liver and both lungs. I was very lucky in terms of how my treatment came through, because the resection was very successful and I didn't need a stoma despite the size and positioning of the primary tumour. I went on to intensive FOLFIRI with Avastin for 6 months, and the response to that was incredible. It cleared my liver, and my lungs were, left lung was clear, my right lung was just left with 3 dots, so I didn't need any further surgery at that stage. After the intensive phase, I was moved on to maintenance chemo, which in those days was a very new thing, and that was a combination of capecitabine and Avastin, and I've been on that now for 5 years. And I've only had 2 minor recurrences. One is a lymphatic one in my neck in 2016, and the following year in my lungs, which was sorted out by ablation. So I've had a very lucky journey through stage 4 bowel cancer. But it does put me in a position where I can speak of personal experience. But I should say, whilst I'm standing here speaking as a patient, and somebody that's been through the operations, goes through an awful lot of chemo, it's very important to say, if you're treating somebody with bowel cancer, you don't only see this. You see the person as well. I'm a professional, I've got a family life, I've got hobbies, I teach yoga, I'm active, I socialize, I travel. When you're treating somebody with advanced bowel cancer, this is who you're treating. And it's important to remember that person. And particularly if you're having conversations with them about diagnosis, telling somebody for the first time that they've got advanced bowel cancer, it could be the 5th, 6th time that day you've told that news to somebody, but it'll be the first time in that person's life they've heard it, and it's devastating, and you have to think of that individual person in that way every time. And from personal experience, I can say the same is true with a recurrence. For you, it may feel routine as a healthcare professional, but for the patient, being told it's back is incredibly scary. So it's very important to think of the person at every point that you're communicating with them. Moving now into the main part of the presentation, and here I'm sharing my personal experience, but also what I've learned from years of being a moderator on the patient forum. So this is experience I've seen from lots of patients from across the UK and to a certain extent internationally as well. And I've broken the presentation into 3 areas, looking at improving consistency and network of care, access to innovative treatments, and how you communicate with the patients. The first section, looking at consistency and network, I'll break into 3 areas. Lack of consistency between major centres, the absence of a cancer network these days of information, and the increasing need for personalisation of care. This is 1 slide each. So first of all, looking at consistency. And this is something I've got experience of. I mentioned I had a very large primary tumour, very low down, and I was lucky enough to have a very good surgeon who did the operation, did the resection with no stoma. But we still find lots of people with having routine bowel cancer surgery who are being offered stomas as a matter of course, and it's not always necessary now. And to avoid stomas unnecessarily is very important. When they're needed, I should say stomas are incredibly important, and the advances in care and how patients are being looked after has made a huge difference. But if a stoma isn't needed in the first place, it should be avoided. And that's something that improving guidelines, setting new standards, improving training of surgeons is something that can help to put that right. With my own experience on maintenance chemo, we do need to see standardization. I see a lot of people on the patient forum who are on what we'd normally call intensive chemotherapy, which is just being extended over several years. And that's a tough thing to go through. And I think a big part of the change that I'd encourage in this is once somebody's gone through that initial 3 or 6 months of intensive chemo, to, as a healthcare professional, view them differently. You have to view the condition now as being a chronic disorder. And in stage 4 bowel cancer, that's quite a new thing. But more and more of us are starting to survive longer and longer. And so the way you'd approach care and the way you'd think about the patient will be different. And quality of life becomes very important. We're going to want to be able to work, be able to travel, be able to do lots of things. And if we're on intensive chemo for many years, that's not going to be possible. So I think there's a mindset thing that needs to change here, as well as establishing best practice through trials, through phase 4 clinical studies, looking at in practice what is the best way to work for maintenance of patients. And the last thing in this is actually a newer part of care of advanced bowel cancer, which is the personalisation of treatment. There's been a lot of success in terms of the rollout of RAS screening, so it's about 90% of centres will test on that, which is good. But BRAF, which was introduced in 2016, 2017, is still quite patchy. And Lynch syndrome should be tested for everybody that's diagnosed with bowel cancer, and that's still a very poor pickup. And if we can get this testing improved, then we can start to personalise the care for the individual patient, and that will make a huge difference to the lifestyle of those patients as well. Most of these things are easily achievable, but they just need people to think about it a little bit more. The absence of network, for me, was something of a surprise, and this hasn't changed in the 2 years since I did the presentation. One of the things that I see a lot on the forum are people who've been told by their doctor, there's nothing more that can be done for you. And they come onto the patient forum devastated, and we give support, we talk to them about what's going on. For some of those patients, we encourage them to go for a second opinion, because we know that there are technologies and techniques and new treatments that are out there that haven't been offered to them. And we see those patients go for second opinion, get successful treatment, and go into remission even, despite the fact they've been told there was nothing else that can be done. And of course, what that doctor meant was, there's nothing else that I can do here. And so the way to put that right is to encourage referral to tertiary centres. And part of that is making those doctors in the local centres more aware of the advances that are available and where they can be referred to. Another way to do that is by signposting patients to patient forums like the Bowel Cancer UK one, because then as patients we can help to encourage other patients to go there. The final suggestion here, I think, is this isn't from a point of view of disciplining the doctor that didn't refer the patient in the first place, but if somebody has asked for a referral for a second opinion and then had successful treatment, the original doctor should be informed of that as an education for them so they can improve their care of people going forwards. The other network, and this is actually a relatively new thing that I've come across, but I'm seeing it more and more, is actually the connection between secondary and primary care. And the example I'll use here is the use of vacuum pumps for patients that have got problems with their wound care. There was an example very recently where there was a patient on the forum who had been said, right, we need to send you home, but we'll send you home with a vacuum pump. And it then took 8 days to get the vacuum pump sorted out. So that patient was in hospital for 8 days longer than they needed to be, blocking the bed, but also causing more problems for themselves. And actually, eventually, when the right person was engaged, it took 12 hours to sort the whole thing out. So we need to have a better connection and standardized procedures for moving patients from primary to secondary care, from secondary to primary care in cases where they need specialist equipment like vacuum pumps. So it's all part of this better connection and a better overall network. Moving on now to the second area of this presentation, looking at access to innovative treatments. I'll talk about this in 2 separate areas, looking at surgical improvements and pharmaceutical ones. First of all, on the surgical side of things, I'll focus entirely on HIPEC. HIPEC is a recent innovation that's been a wonderful advance for people that have got peritoneal mets. Previously, there was pretty much nothing that could be done. It is quite rightly only being offered at certain specialist centres. It's a huge operation and it's a big thing for the patient to go through. But it should be offered routinely, it should be at least as a screening be offered to everybody with peritoneal mets. And it's not. We're getting a really patchy rollout. And in some parts of the country, in Wales, for example, there is no HIPEC. In Scotland, it's not a routine thing. And what we're finding again is people are having to fight to get that treatment. And what I'd say in this day and age, when you've got an innovation that's being rolled out as well as HIPEC is, it should be routine. So everyone should be getting screened that's got peritoneal mets to see if they're going to be suitable, and then offered that as an option. They may choose not to go through with it, but it should be their choice as a patient. On the pharmaceutical side of things, we know that there are excellent, life-changing, life-saving treatments such as Avastin, bevacizumab, that are not available to NHS patients. And the shame here is we're talking about 50% of patients, those like me who have the RAS mutation, aren't going to be effective with the NHS-sanctioned biological therapies. This is the only one that is available. As a private patient, I have access to it, and it has worked very well for me. And it's a shame that that's not available routinely for NHS patients. Now, I realise from a cost perspective that there is quite a constraint there. So I'm not saying it should be first-line therapy for everybody. But if somebody with the RAS mutation has gone through conventional chemotherapy and there's nothing else that can be offered, they should be given a chance to try Avastin to see if it's going to do the job for them. And for the patients in the other 50% that have the RAS wild type, who can have the biologicals, panitumumab and cetuximab, they're in the situation where if they have a break in therapy, if they've had an infection or they had to have surgery, they can't restart that treatment. And bizarrely, if they've gone into remission and 1 year later, 2 years later, they get a recurrence of their cancer, they can't go back onto the treatment that they know has worked for them. That surely is unethical. And linked to both these things, we have a situation in the NHS where we have patients that are failing on traditional chemotherapy or who are having recurrences who are being denied these innovative treatments and instead having to hope to go into clinical trials of unproven therapies when these treatments are available and could be used in them. And again, I would suggest that that is unethical. These are things that are not going to be easy to change on a day-to-day basis. They do need campaigning, but the pressure is on all of us to make sure that these changes and improvements can take place. The final section of this presentation is looking at improving communication between healthcare professionals and people with advanced cancer. And here I'd look at this in 4 different areas, looking at the tone of conversations, how you set patients up to improve their outlook, what words you use, what terminology you use, and if you talk about prognosis and statistics, how you talk about them. And again, 1 slide on each of these. At the moment, and quite rightly in the NHS, we've moved to an area of it's full disclosure. So nothing is hidden from the patient. And as I say, that is quite right, and I think it's to be encouraged, and it makes a huge difference. However, what we see through the forum is more and more often what that turns to is a communication that is brutally honest and bordering on pessimism. And that sets the patient up for failure. It sets them up scared. They approach their treatments negatively. And we know the nocebo effect, which is well proven, and this is really pushing people towards that. Now, I'm not saying that we should be promising the earth to everybody, and somebody with stage 4 bowel cancer, when they're diagnosed, should be told, we will definitely cure you. But we should be looking to have a tone of cautious optimism in the conversation. And that's words like, we're going to do our best for you. We've the MD-tier meeting, we're going to work together and put a program together that's going to do the best we can for you. Or talking to them about the benefits of the treatments that you're going to try with them. Linking into that is the next section, which is looking at setting up for best outcomes. And it's really important to talk about why you've chosen a certain regimen or a certain medicine for that patient. And I can tell you, I've had excellent care, but even in my case, all that was talked about was side effects. And the side effects on most of the treatments that we get are really quite scary. But no one sat down and said, the reason this regimen has been chosen for you is because this is what it can do for you. Or in my clinical experience, I've seen this work so well for people like you. set things up more positively in that respect. And linking in with that, how to proactively tell patients how to reduce side effects. I'm on capecitabine and have been for years. One of the most common side effects is the plantar palmar problem. And the easy way to deal with that, and certainly to reduce the severity, is simply using moisturizers, really good quality moisturizers. It should be a routine thing. If someone's starting capecitabine, they're told, you'll need to do this. And that sort of tip exists for lots of things. If you're going on to oxaliplatin, wearing gloves to stop your hands from getting cold, it's that sort of thing. All of these things make a huge difference to the patient. We share this sort of practical stuff on the patient forum, but that's only good for the people that have found our patient forum. This should be a routine part of communication from doctors and nurses to the patients at initiation of treatment. Another thing is to encourage a better psychological approach. Now, I've been very lucky that this worked with me, and that's to view chemotherapy effectively as their friend. It's their ally. It's there to help them. That means that for the past 5 years, when I have my chemo cycle, I don't dread it. I welcome it because I know it's doing me good. Of course, the bizarre thing is I can't feel it doing me good. I can only feel it causing side effects. So it's important to put this psychological point into the patient's mind, again, at the start of treatment and throughout treatment. It's the good that the drug is quietly doing under the surface so that they welcome it in. And this is, I guess this is also a placebo effect. If you believe the drug is going to help you, it's more likely to help you. And linking into all of this, I know I've mentioned the patient forum, but it's referring patients to places where they can get information and support proactively. And this would be at the initial consultations, at follow-up consultations, and I would encourage people to be pointed towards the Bowel Cancer UK website, because there's a lot of really good booklets there that are very easy to read, and that's how I first came across the charity. And also the excellent online forum, which is a safe space, because it's moderated by other patients and supported by the charity, so it's not putting over scare stories and that sort of thing, so it is a safe place for people to go to. But I think with simple approaches like this and changing this in communication, that can make a huge difference. The language is something really quite fundamental, and it is an odd thing. It's a particular thing, I think, within cancer. There's a real fixation around whether someone is curable or incurable. And it's the only disease that I've come across where we really hit on this so much. In diabetes, hypertension, we don't label somebody as incurable, even though they are. We don't cure those diseases. So I understand saying to somebody, we're going to try and cure you, but if cure isn't possible, why give them the blunt hammer of a label of you are incurable? And we come across that a lot, and I can tell you that is absolutely devastating for a patient to hear. The alternative is just simple. You have advanced bowel cancer, you have stage 4 bowel cancer. Why say it's incurable? And in a similar way, why use the word inoperable? Speaking to a lot of surgeons, I know that in the mind of the surgeon, inoperable is often a temporary thing. But the way it's communicated to the patient, it always feels as though it's a sentence. Inoperable, that's it, I can never be operated on. And I know so many people who've been told they're inoperable, responded well to chemo, and then had very, very successful operations. And so just simply saying things like, we can't operate right now, let's see how you respond to chemo. Because that then gives them some hope. They know it may be a temporary situation. You're not promising them you can definitely operate in the future, but you can give them a reason to really try and make the most of that chemo regimen that they're going to go on to. And I can tell you, after the first presentation that I gave of this, one of the surgeons contacted me a couple of days later to say that she was in a consultation with one of the patients, and she was about to say inoperable, caught herself, remembered the presentation, changed the phrasing, and the outcome of the consultation was completely different to what she'd expected. And that's now become a routine part of her practice, just by not using that word. Another word that, as patients, we struggle with is palliative and palliative care. Because I understand in a clinical setting, you know fully what palliative is. But if a patient is told they're going to be put onto palliative care, they think they're going to die, and they're going to die very soon. And for a lot of us, that's not the case. And again, I'll go back to the example I used here. When we treat somebody with hypertension or diabetes, in those cases, we put them onto palliative care, but we don't use that label. So why do we have to use that label when it comes to treating advanced cancer? Why not say, what we're going to do is we're going to try and control your cancer. We're going to put you onto, the label is maintenance chemo, continuous chemo. In that circumstance, it sets the conversation up differently. It sets the expectation up correctly for the patient, but it takes the fear away. And it's the same throughout all of these examples. They're very simple changes just to the language, and it will make a huge difference to the person that you're speaking to. The final part of this section is prognosis and statistics, the old thing, lies, damn lies, and statistics. There's a feeling sometimes that you have to tell people what the stats are, what the prognosis is, and it's not always necessary, certainly not at diagnosis. If you have to, if the person is in a really desperate situation, obviously you have to tell them things and you have to be open with them. But if it's not needed at that time, then don't force it on the patient. And if they do ask and you're not in a situation to know, be willing to say, we don't know yet. This was an example for me. At my diagnosis, I said to my oncologist, okay, what's the prognosis going to be? And he said, until we see how you respond to chemo, we don't know. Give it the 6 months of chemo, and then we can see how you're doing. That worked for me. I accepted that quite happily because I trusted my doctor. And what it meant was that I could then approach my chemo to get the best out of it, because I wanted that conversation to be as good as it could be when it came around. So be willing to put that, not put it off as a scare tactic, but positively to say, let's see how you do. We don't know yet. But if you do talk about statistics, please put them into perspective. Because again, most of the people you speak to don't deal with these sorts of stats and prognosis figures routinely. Again, it's a routine thing for you, perhaps. But if you say to somebody, there's a 60% chance of you surviving the first year, or we think it's going to be a year, you've only got a 6% chance of or a 7% chance of getting to 5 years. That's a scary thing to hear. But if you put it into perspective and say, this is what the general stats say, but it's not a predictor of you. We don't know how long you're going to live for because there are no stats on you. Those figures, and again, it's worth saying this, the figures are really good for comparing country to country and even centre to centre, and for showing how survival is changing over time. And that's a great one to talk to a patient about because, of course, survival rates are increasing phenomenally. In advanced bowel cancer, in the 5 years I've had the disease, I've seen it increase from about 4% to about 7%. So there are some really good advances, but it's all about putting those stats into perspective if you have to have that conversation. It's a little bit more time in the consultation, but it can make, again, a big difference to the patient. That brings me to the end of the presentation. I'd like to just summarise by first of all saying the presentation is highlighting gaps and areas that can be improved, but I really would also like to reflect on the fact that even in the short time that I've been around this disease, I've seen so many advances and improvements, and the survival, as already mentioned, is increasing phenomenally. So we're in a positive place and an improving place. Where I've been talking about here is how we can improve things even better. And by improving the network and consistency across the country and communicating with patients, these are relatively easy fixes that you could do tomorrow and make what is going to be an immediate and really positive impact on the patient. I do realise that the access to treatment is a bigger issue, and it's the decisions on that take place at a higher level, but the onus is on all of us to try and make that happen. I hope you find this to be an interesting presentation. If you'd like to see more, Strive for 5 is a programme that I set up alongside the charity, and it's all designed to give more hope to people with stage 4 bowel cancer. The website is there, strivefor5.org. The Bowel Cancer UK website is something that I would definitely say to go along to. There's a lot of great support stuff on there, and again, that's where you find the patient forum. And I'm very grateful to the Association of Coloproctology who initiated all of this, and the whole impact idea came along from them. Thank you for your time.